Hey everybody, welcome to Mental Health is a Verb. Dr. Jake here. Thank you for tuning in to this topic. Today's topic is substance abuse / addiction. Remember, we focus on assessment and interventions. This is usually where you see the bulk of your nursing style questions. And remember to prioritize your interventions per Maslow's hierarchy of needs. Now, you can see here, excuse me, how I've kind of sketched out what I believe are the key concepts and key takeaways for this particular topic. It is important not to forget that addiction also extends to other behavioral type subjects or topics or things, if you will, that are not necessarily tied to substance abuse. Excuse me, such as gambling, sexual activity, eating. Those are some examples of addictive behaviors that not necessarily tied to substance abuse, okay? Now, assessment. If it is related to a substance, what kind of substance is it? If it's an alcohol type substances, hard liquor, wine, beer, usually what you see documented is an ETOH issue, ethanol issue. The green leaf there is supposed to be a cannabis leaf. And these are just 3 examples of substances. Of course, there's other substances, okay? Now, I thought it important to include what this is supposed to be as like a little orange pill bottle with an RX for you to think prescription. It may not be an illicit substance. Maybe it's something they've been prescribed. There is a psychotropic medication class that I can think of right off the top of my head, benzodiazepines, which has a potential for abuse / addiction, developing a tolerance, that sort of thing. Now, before I get too far ahead of myself, the concepts that I see when you're building your scaffolding particular to this topic are safety, addiction / withdrawal, and therapeutic communication. So specific to assessment, what type of substance is it? How much do they use? How often do they use it? When was the last use? Okay, that particular 2 of those in particular, how much and last use, you might put that puts you in the mind of potential for withdrawal. And so when we jump down to interventions, I want you to remember those 2 questions when we think about withdrawal and substitutive type therapy. So safety, the arrow going up when we think about assessment, actually ties to those oranges browns questions. What type of substance, how much, how often, and when was the last use? Now, other things to think about, they specific to assessment are, do we have a validated tool to assess this person's withdrawal? Okay, the CWAL, Clinical Institute of Withdrawal of Alcohol Scale, and the ARS revised, okay, alcohol revised scale. You typically see this used in an acute care environment to assess someone's withdrawal from alcohol. The CAGE questionnaire, generally specific to someone personal assessment, okay? The CWAL, typically what you see is a scoring, and then we medicate based upon the score. Because when the body gets used to a substance and you withdraw it, whether that's voluntary or say, this person has checked themselves in, or maybe they perhaps involuntary, maybe they've been legally mandated to seek treatment because it's caused such dysfunction in their life and they have an issue with it. Another validated tool is a clinical opioid withdrawal scale, because if you've noticed in the past few years, we have an opioid addiction epidemic. Other things to keep in mind related to assessment are the purple pinkish details over here. The age of onset. Has there been a change in school / work performance? That puts you in the mind of that dysfunction, which is a hallmark of, say, if someone has any type of mental health diagnosis type concern. Is it causing this person dysfunction, or has it related to dysfunction in their life? What about stress factors? What about, have there been adaptive coping mechanisms that have helped this person in the past that we might either promote or steer them towards, or an opportunity to educate them towards adaptive coping mechanisms? Do they have a social support network? If not, how can we build on that? Okay. And do they have a personal concern related to their use? Now, safety, let's move down and think about the safety needs related to intervention. In the acute treatment, like in the acute care environment, we want to think about safety related to withdrawal. We just talked about that when the body gets used to a substance, and substitutive therapy. Now, some medications that you might see some text questions related to: fluminenazole, otherwise known as Ramazicon, but general, know the generics. Fluminenazole, Ramazicon, the trade name, is an antidote for benzodiazepines. Naloxone, otherwise known as Narcan, a trade name, for an opioid overdose. Not to be confused with, but you probably should also know this one, naltrexone, which can help someone with an opioid and actually an alcohol abuse issue. Methadone, typically what you see this used, or when you see this used, is the long-term treatment. It is an opioid itself, but it doesn't give, it's kind of like has lower incidence of those high highs or euphoria that someone may get with a stronger opioid. Okay. So typically you may have heard of a methadone clinic where someone can go and get their dose of methadone for the day, and then they'll be able to function in day-to-day life. Nicotine, people may use nicotine gum, nicotine patches, or even bupropion, which is technically an antidepressant. Trade name that typically you see associated with this, specific to nicotine, is Wellbutrin, and it helps with smoking cessation. ETOH, remember what we just said about ETOH, that being the chemical name for alcohol, and that's usually what you see documented. Disulfiram, also known as Antabuse. If someone drinks and they're taking Antabuse, they're physically going to feel ill. Okay. Benzodiazepines and chlordiazepoxide. Chlordiazepoxide is technically a benzodiazepine. Remember, your benzodiazepines end in lam and pam. But chlordiazepoxide, otherwise known as Librium, and lorazepam generally is what you see as far as your other benzodiazepine, is used for someone going through withdrawals of alcohol, the ETOH. Okay. So those are the medications. Now, other things to keep in mind related to safety and acute care treatment: one-to-one observation. Think about their suicide risk, their fall risk, seizure precautions, ongoing, more soft interventions. You know, notice I've got the red font tied to acute treatment, things to be on the top, the forefront of your mind related to safety, but ongoing and more long-term interventions. Always providing emotional support, being non-judgmental, trying to remain objective. You know, you may need to check yourself. How do you feel about substance abuse and addiction? Because remember, as nurses, we take care of all walks of life and all sorts of people that present with different issues. In the acute phase, you may need to reorient this person and have PRN, like as often as you need to. Promote their use of self-help groups, such as Alcoholics Anonymous, which typically something that you may read about associated with Alcoholics Anonymous is the 12 steps. For families and friends, they may go to Al-Anon. There's also Narcotics Anonymous. There's all sorts of self-help groups. So the main key takeaway with this self-help groups is, what else can we arm this person with to make them successful if they have either, like I said, voluntary or been mandated to seek help. And then last, self-responsibility, self-accountability. You want to promote this person to accept, yes, I have a problem, and yes, I need help. Thank you guys for tuning in, and I'll see you on the next topic. And yeah, hey, lastly, maybe you might try sketching this out. Concept maps kind of promote the scaffolding, if you will, in your brain to help you compartmentalize the vast amounts of knowledge that you have to know when you go through nursing school and becoming a nurse. Thanks. See you later.